Welcome to the NAHA teleconference brought to you by the National Association for Holistic Aromatherapy. To learn more about NAHA, please visit www.naha.org. The information being presented is not intended to diagnose or take the place of professional health care. Before using essential oils and aromatherapy products, please consult with a professional aromatherapist. Tonight's presentation topic is Basics of Pharmacology for Aromatherapists. This educational teleseminar is being presented by Dr. Jowie Power. Dr. Jowie Power is a retired neuropsychologist and former assistant professor for neurosurgery at the Medical College of Georgia. She has over 25 years of clinical and research experience in both inpatient and outpatient settings. During that time, she has been a student and practitioner of alternative healing methods, including aromatherapy, herbal medicine, Chinese medicine, and other energetic healing systems. She is the director of the Highland School of Natural Healing, where she currently offers courses in aromatherapy. She is a consultant for Artisan Aromatics essential oils and a well-known writer in the fields of aromatherapy and alternative healing. Dr. Power is a professional member of NAHA and a contributing author to the NAHA Aromatherapy Journal. To learn more about Jowie Power, please visit her websites at Artisan Essential Oils at www.artisanessentialoils.com, as well as Highland School for Natural Healing.com. And I'd like to take a moment and welcome Dr. Jowie Power to the presentation. You can go ahead and get started.
Thank you so much, Kelly, not just for the introduction, but for all the work you've done to pull this webinar together. I'm not sure people realize how much work you end up doing on this. And thanks to all of you who have logged in tonight. From what I understand, we have quite a big group, and I don't really know what various types of backgrounds people might have in pharmacology. But as the description on the NAHA website has indicated, my plan tonight is to present a very basic introduction to just some of the concepts and ideas in pharmacology that I think will be meaningful and useful to aromatherapists who don't have any prior training in this area and who don't have strong backgrounds in chemistry, math, and physiology. So instead of talking about any of the very technical aspects of pharmacology that we could talk about, I'm going to be focusing instead on things that I think have practical implications for how you actually use essential oils, and I'm hoping that some of this information will also help you read and interpret medical research on the pharmaceutical properties of essential oils. And I actually have quite a bit to cover, given that we only have an hour, and I apologize in advance for the fact that by necessity I may be speaking a little quickly. If you're feeling overwhelmed by the time we get to the end of this, you may want to go back and listen to the recording again. So let me just give you a little overview about the topics we'll be covering. And I need to move to the next slide. Hopefully I can do this properly. All right. So as you can see on the slide, there are two main divisions of pharmacology, and we'll look at some key concepts in each of these areas. The two divisions, basic divisions of pharmacology, the main divisions, are pharmacokinetics and pharmacodynamics. And very simply defined, pharmacokinetics is just the study of what the body does to drugs, and pharmacodynamics is the study of what drugs do to the body. And these are really just opposite sides of the same coin. And the important thing to note here is that these two divisions reflect the fact that there's an interactive relationship between drugs and the body, and it's through that interactive interactive action that drugs exert their effects. And I just had a note handed to me, Kelly. I guess this is to you. Joanne Brennan wants to be added to the seminar, and she left her email, but I don't guess there's anything we can do about that. All right, so these are two sides of the same coin. I'll be talking about pharmacodynamics first, and within that topic, I'll be focusing specifically on the issue of receptor binding, because receptor binding is really the core concept for understanding how drugs work. It's the physiological mechanism that allows drugs to alter cellular functioning in order to exert a therapeutic effect. And a couple of concepts that are important for understanding receptor binding are affinity and intrinsic activity. And I'll define and explain those. And once I've done that, we'll be talking about the concept of agonist versus antagonist. And that'll wrap us up for that. In the second half of the hour, we're going to look at pharmacokinetics. And the main thing we're going to look at in this realm is this issue of absorption, which is how drugs or other substances get absorbed into the bloodstream. Because this particular topic has some very important practical information about the best ways to administer essential oils in various circumstances. And it has some very direct relevance to this controversial issue about oral use of essential oils. So before we get started with the main discussion, there are several little caveats or cautions that I want to share with you, and most of these really pertain to limitations of pharmacology. And the first limitation is that although pharmacology can help you understand how plant medicines do some of what they do, they can't explain how plant medicines do everything they do. And this is because plant medicines, including essential oils, have energetic effects that drugs don't have. Drugs mostly are aimed at managing symptoms, but plant medicines have some actions that go beyond that, and I'm talking about things like tonic actions and adaptogenic actions. And pharmacology is not going to help you understand that aspect of plant medicines. That's what you really need to study something like Ayurveda or Chinese medicine for. The next limitation of pharmacology is that it doesn't tell us everything we need to know about how inhaled essential oils are able to exert direct effects on the central nervous system through stimulation of the olfactory nerve. And of course, this is a very important aspect of aromatherapy, because this is a unique property that essential oils have. They're able to affect the brain, and through the brain, they're able to affect much of the rest of the body simply by the fact that when you inhale an essential oil, the constituents of that oil will stimulate the olfactory nerve. That has nothing to do with pharmacological principles that we'll be talking about tonight. The third thing I want you to be aware of is that when we talk about essential oils from a pharmacological perspective, we are virtually always talking about the constituents of those oils and not the oils per se. It's not lavender essential oil, for example, that undergoes pharmacological processes. It's the constituents of that lavender oil, the linalool and the linalool acetate and the camphor and all those other constituents that undergo pharmacological processes and that have the ability to exert therapeutic effects. And the final point here is just that the principles of pharmacology that we'll be discussing tonight apply to how the majority of drugs work, but they don't apply to how all drugs work. And I've just kind of listed there briefly some other ways in which drugs can work. Antacids, for example, work by causing chemical reactions. Bulk-forming laxatives work because of their physical properties. So there are a few drugs that can act in ways other than what I'll be talking about tonight, but most drugs, the majority of drugs, work according to these processes. And what should be up on your screen right now is just a slide that gives a kind of succinct statement about how most drugs work. And you can go through that at your leisure and read through it. But I'm going to be talking about that now. Unlike those few drugs that I've listed on the previous slide that exert their effects in a mostly local fashion, the majority of drugs act by binding to specialized receptor proteins that are located on cells that are somewhere else in the body other than the point at which the drug was introduced. If you take an injection of something like Tagamet, for example, Tagamet is usually used to reduce excess acid in the stomach. And when you take that by injection, the molecules of that drug have to get from the point of the injection to their particular receptors, which in the case of Tagamet happen to be found on the cells of your stomach lining. When you take a drug like Cardizem, that's a common drug used to treat high blood pressure, the receptors for that drug are found on the cells of cardiac muscle. So when you swallow a Cardizem tablet, those molecules have to travel from your stomach to your heart. So different drugs need to bind to different receptors, and they have to travel in the body to get to those receptors, and they do that by getting absorbed into the blood and moving around in the blood, and that's why this process of absorption is so important. Receptor binding really, when you get to the bottom of it, it's really just basically about communication. And when some natural molecule that your body produces or some drug molecule binds to a receptor, it creates a connection that enables that drug or that natural molecule to communicate with that cell and tell that cell what to do. Cells need instructions in order to do the right thing, and receptors are the vehicle through which they receive those instructions. Drug molecules, like natural molecules, use receptor binding as a method of delivering messages to cells. And basically, the type of message that any of these molecules can deliver, or that a drug molecule will deliver, will simply tell that cell to increase or decrease some process that the cell normally carries out. Basically, a drug is not able to tell a cell to do anything that it wouldn't normally do. It can only tell it to do more or less of what it does, or to do it faster or slower. Now, this is probably obvious, but I'll say it anyway. One of the important things to understand about receptor binding is that we don't have receptors so that we can take drugs. Mother Nature didn't give us receptors in order to enable us to take drugs. Receptor binding is just the body's natural operating system. And ultimately, everything that happens in the body happens because the various hormones and neurotransmitters and other regulatory molecules that we produce naturally, all these things like estrogen and serotonin and these other familiar substances, these all bind to specific receptors and tell the cells that those receptors are on to do something. The drugs and plant medicines that we use are able to do what they do because they are structurally similar. They have a similar shape, or at least some portion of their molecule has a similar shape to the regulatory molecules that we produce naturally. And that structural similarity between drugs and natural molecules enables drugs to utilize our basic operating system. So opiate drugs have been really widely studied, so we talk about them as examples a lot. But opiate drugs like morphine are effective for pain control because they bind to the same receptors on cells in the central nervous system that our own endorphins bind to. And like our own endorphins, when they bind, they download a message through that connection that tells those cells to stop sending pain signals. This receptor binding that I'm talking about for drugs is also an important mechanism of action for essential oil constituents. And it's one way, it's a major way in which essential oil constituents can have therapeutic effects. So it's been shown, for example, that thyme essential oil has the ability to lower blood pressure a little bit. And it's able to do that because it has two constituents, thymol and carvacrol, that bind to receptors in cardiac muscle and act as calcium channel blockers at those receptors. In other words, they tell those cells to decrease the amount of calcium that can get in, and this in turn allows those cardiac muscles to relax and blood pressure drops as a result. And this is the same way the cardizem works, the cardizem that I just mentioned a moment ago. It's a calcium channel blocker, and it works in the same way that the thymol and carvacrol work. Now let me clarify that I'm not suggesting because of this that you can tell someone who's taking cardizem that they can stop that drug and start using thyme essential oil, because thyme essential oil is not going to have the same robust effect that cardizem has. So please don't take that as a sign that you can take someone off a blood pressure drug and tell them to take an essential oil. But conceivably, there could be situations in which an essential oil might be able to help someone with high blood pressure. And another thing that tells you is that there is potentially an interaction between a drug like cardizem and an essential oil like thymol, because possibly the thyme oil, at least theoretically, could potentiate the action of the cardizem. So let's go to the next slide then. And I'll have a picture for you. All right, this is just a little more detail on how drugs work. Let's see what we got here. All right. Really just what I want you to look at on this slide is a picture. And this is just an artist concept of this whole process of receptor binding. So it's a graphic illustration of the concept. And you can just see here the blue receptor is embedded in the cell membrane. The drawing of that cell membrane shows what's called the phospholipid bilayer that a membrane is made of. This particular receptor is just embedded in that membrane. Some receptors are found inside the cell. The drug molecule is the little red triangle. It's shaped like the indentation in the receptor. You see that the drug molecule binds to the receptor on the right. It sends a message inside the cell, which is indicated by that arrow, and it provokes a response from that cell. Now you notice the word ligand that's above those receptors on the left and right. Ligand is a good term to know because you see it a lot in pharmacology, and it just refers to anything that can bind to a receptor, whether it's something that the body produces naturally or something that we introduce into the body, like a drug or a plant medicine. So endorphins are ligands, morphine molecules are ligands, thymol and carvacrol are ligands. All these things are ligands because they can bind to receptors. There are many different kinds of receptors in the body, and these are there to accommodate the many different kinds of ligands that we produce naturally. We have opiate receptors for endorphins. We have dopamine receptors for dopamine. We have these beta receptors for epinephrine, which is what we used to call adrenaline. So the receptors are specific for a specific ligand. A beta receptor will accept that epinephrine, but it won't accept serotonin, meaning that it won't allow it to bind. When a ligand is able to bind to a receptor, it activates that specific receptor cell in a specific way to produce a specific effect. So for example, again, when that morphine binds to an opiate receptor on a cell in the brain, it tells that cell to stop sending pain signals. If a drug was able to bind to just one kind of receptor, it would exert just one kind of effect. But virtually every drug can bind to more than one kind of receptor. And this is one reason that virtually all drugs exert more than one kind of effect. The Tagamet that I spoke of earlier reduces stomach acid by binding to cells in the stomach lining. But we found not too long ago that it can also exert entirely different therapeutic effects because it also binds to a different type of receptor that's found on certain immune cells. And the effect that's produced through that connection enables Tagamet, which we usually use for stomach acid, to exert a therapeutic action against certain types of viral warts. So that's an example of a drug that has two different therapeutic actions because it can bind to two different receptors. But not all of the dual actions that are produced that way are going to be beneficial. And this is also one way in which side effects are produced. A lot of pharmacologists will tell you that the dream drug, the hypothetical ideal drug, would be a drug that could only bind to one receptor and produce one effect. But we haven't been able to make drugs like that so far. A completely different way that a drug molecule can produce dual effects, which could theoretically also be either therapeutic effects or side effects, is when some specific receptor to which a drug binds is located in more than one organ or organ system. Now, in the case of the Tagamet, those receptors were located in different places, but they were the same receptors. Or let me see, they were the same receptors, but they were located in different places. All right, but anyway, you can bind to receptors that are located in different parts of the body. And a good example of that is, again, opiates. Opiates reduce pain by binding to opiate receptors in the central nervous system, but there are also opiate receptors in the gastrointestinal tract, in the gut. And when opiates bind to the receptors there, the end result is that they cause constipation. So these are two reasons why drugs have side effects and can exert different types of actions. And I'll sum this up. That'll clear up a little of the confusion I just had. One is that virtually every drug can bind to more than one kind of receptor. And two, some given receptor type to which a drug binds might be located in different tissues. So these are ways that you get dual effects. There are just a couple of more concepts that I want to mention about receptor binding. Let's move down to the next to the next slide. The interaction between a drug and receptor sites is governed by two things, and these two things are called affinity and intrinsic activity. Affinity means the same thing basically as affection, and in simple terms, a drug's affinity for any given receptor is simply its tendency to bind to that receptor. And any given drug will have varying degrees of affinity for some of the specific receptors that it can bind to. Morphine, for example, has a high affinity for opiate receptors. That means it just loves opiate receptors. And anytime a drug has a high affinity for a receptor, it really wants to go there, just like you really want to be with somebody you like. This is really just kind of a matter of who likes who. So a drug with high affinity will almost certainly bind to an available receptor, even when it only has fairly low concentrations in the blood. And once that drug with a high affinity for a receptor has bound to it, it's likely to stay there longer than a drug with weaker affinity would stay there. So it's going to have a longer effect. You want to be with somebody you like for a long time. And it's the same way with drugs and their receptors. If a drug has low affinity for a receptor, it's less likely to bind to it, and generally it would need to achieve a higher concentration in the blood before it would do so. The low affinity drug is also not likely to stay in the receptor as long as one would if it had higher affinity. And finally, if a drug has no affinity for a given receptor, it will never bind to it no matter what. Hell will freeze over before a drug with no affinity for a receptor will bind to that receptor. So affinity is just a way of talking about how likely a drug is to bind to a receptor. And the more likely it is to bind, the less its concentration in the blood needs to be before it will bind. The other concept that we've got on the slide here that plays a part in governing the interaction between drugs and receptors is intrinsic activity. And intrinsic activity only applies to the relationship between a drug and the receptors that it will bind to. It has nothing to do with drugs and receptors that they won't bind to. It refers to a drug's ability to cause an effect once it has become bound. It refers basically to whether or not a drug can activate a receptor that it binds to and prompt it to initiate a cellular response. For our purposes tonight, the main importance of affinity and intrinsic activity are that they will enable us to understand the difference between so-called agonist and antagonist, which are terms that are applied to drugs based on the types of actions they exert. So let's get to that slide. Ooh, too far. There we go. An agonist is a drug that binds to a cell's receptors and triggers an action in that cell. So that means that it has both affinity and intrinsic activity relative to that cell and its receptors. Morphine produces pain relief because it's an agonist at opiate receptor sites. Excuse me, I just dropped the headphone. Hang on. All right, I think that should get me back here. So morphine is an agonist at opiate receptor sites, which means it binds to those receptors and then it activates those cells to stop sending pain signals. Amphetamines are agonists at our adrenaline receptor sites, epinephrine receptors, now they would be called. And in fact, they activate those sites even more powerfully than our body's natural epinephrine does. So they not only have affinity for those sites, they also have a very high intrinsic action at those receptors. So an antagonist now, which is the other type of drug, is a drug that possesses affinity for a specific receptor, but it has no intrinsic action there, which is to say that an antagonist will bind to a specific receptor, but it will not activate it because it has no intrinsic activity at that receptor. And if you've kind of been able to keep up with the logic in this, you may be asking now, what in the world is the point of having a substance that will bind to a receptor if it's not going to activate it? And that's a good question, but in fact, drugs that do that have a very important application, because what these drugs do, once they bind, they have filled up that receptor. And that receptor then cannot be activated by anything else, like our own natural hormones or neurotransmitters. The drug, the antagonist, has, kind of just taken over the receptor site. It's filled it up, but it doesn't do anything there. By virtue of the fact that it's filled it up, though, nothing else can do anything there either. And that's exactly how these drugs that we call beta blockers work to lower blood pressure and to suppress some of the symptoms of situational anxiety. Beta blockers bind to the same sites that epinephrine binds to because they have an affinity for them. So they fill them up, but then they don't cause any effect because they have no intrinsic action. And by occupying those sites, the beta blockers prevent our body's own natural adrenaline from attaching there and activating them. And for example, in terms of beta blockers being used for situational anxiety, when you've got to do something like give a presentation, your adrenaline, your epinephrine goes up and you get all these symptoms as a result. You get rapid heartbeat and you might get changes in your breathing and shaky hands, and a beta blocker suppresses all of those things because it fills up the receptor sites that adrenaline acts through. And I apologize for going back and forth between epinephrine and adrenaline. They're the same thing. We used to call it adrenaline, now we call it epinephrine. All right, so that's a very brief summary of receptor binding, and I hope that contributes a little bit to your understanding of how drugs do what they do. The next thing I want to move on to is pharmacodynamics, which is that division of pharmacology that deals with what the body does to drugs, pharmacokinetics. And pharmacokinetics encompasses 4 basic processes that include absorption, distribution, metabolism, and excretion. And all of these are important, but because we've only got an hour, I'm just going to focus on absorption because I think it has a lot of practical relevance. One of the key things to get about drugs is that the molecules of any drug have to get from the point at which the drug was administered to the place in the body where the specific receptors for that drug are located. And the way that they do that, as I said, is being absorbed into the systemic blood circulation at their point of administration. And again, this is why absorption is so important, because if a substance can't be absorbed, it won't be able to have any effect because it won't be able to reach its receptors. And that's actually a pretty large problem in pharmacology. We've identified a lot of drug molecules that have the potential to have really good therapeutic actions, but we can't figure out how to get them where they need to go because they're not absorbed well through the routes that we need them to be absorbed through. A concept in pharmacology that's closely related to absorption is this concept of bioavailability, which should be up on your screen now. Bioavailability is simply the percentage of the dose of a given drug that can be absorbed into the systemic circulation by a specific route. And in aromatherapy, our usual potential routes of administration are described as including topical application, inhalation, and ingestion. Although one of the important things to remember in this is that virtually any time we apply essential oils topically in ordinary practice situations, anytime we apply them topically, we're getting some inhalation of those oils as well, and sometimes we're actually getting quite a bit of inhalation. So it might be more accurate to say that the routes we can use in aromatherapy include combined inhalation and topical application, number 1. Inhalation without topical application, number 2. And ingestion, number 3. Bioavailability varies from drug to drug depending on how easily that drug can cross other membranes, and so it varies by the route of administration by which the drug is given. And when a drug has a high degree of bioavailability by a given route, it's going to be able to work effectively by that route, but the risk of adverse reactions will also be higher by that route, especially since a lot of adverse reactions are dose dependent. They're dependent on the level of concentration of the drug in the blood. So many side effects don't emerge until your blood level reaches a pretty high point. And that's one way in which a higher bioavailability can be a hindrance. The risk of things like organ toxicity or fetal toxicity or spontaneous abortion or drug interactions all get higher when your bioavailability gets higher. And in most cases, that'll happen with ingestion. If you take a drug or theoretically an essential oil component by intravenous injection, its bioavailability is 100%. All of it is there in the blood because you put it directly there. Its immediate bioavailability is 100%. If you administer a drug or essential oil component by any other route, its bioavailability is going to be less than 100%. And sometimes it's going to be a great deal less, because as drugs get absorbed into the body by any given route, they have to pass through various barriers that can cut them back. Different routes of administration have different barriers, and that's why bioavailability will be different for each route of administration. If you take a drug by mouth, for example, one of the barriers that it has to get past somehow is the acids in the stomach. And if some of that drug is destroyed by those acids, its bioavailability is going to be reduced. It might be better to give that particular drug through inhalation or topical application because stomach acids won't affect it through those routes. Drugs that you take by mouth also have to go through the liver before they can get anywhere else in the body. This is called the first pass metabolism. And many drugs get partially or even completely destroyed by enzymes in the liver. Nitroglycerin, which is used to stop a heart attack, is pretty much completely destroyed in the liver. So if you're starting into a heart attack and you're carrying those little nitroglycerin pills, you better remember to put them under your tongue and not swallow them. Because if you swallow them, you might as well sign your will at the same time, because they're not going to work by that route. And one of the problems in using essential oils is that we don't have much research on the bioavailability of essential oil constituents. We don't know, for example, in a lot of cases, what constituents might be destroyed, say, for example, in the stomach or the liver. But what information we do have suggests that bioavailability for essential oil constituents can be as high as about 96% with oral dosing, but it won't necessarily be that high for every essential oil constituent taken by mouth. And there is some important research that has something to say about that, because one of the things we know is that the essential oil constituents known as esters are pretty much destroyed in the stomach. And since esters have important therapeutic actions, it's probably not a good choice to administer essential oils with a good whose actions depend on esters by mouth, especially if you don't use a vehicle that protects them. Lavender protects them in the stomach. Lavender essential oil is the perfect example. It's high in esters, and those esters are said to account for a lot of its therapeutic effects. So if you take lavender by mouth, you're probably going to lose some of the effects you want. And of course, one of the very important things in all of this is that a whole lot of the therapeutic actions that we want to get from essential oil use probably come from stimulation of the olfactory nerve. And if you take them internally, you won't be getting those effects. You know, you might get a little because you might inhale a little bit of oil when you're putting the drops in water or in a capsule, but for the most part, you're not going to be getting those effects. So while oral use of essential oils, which seems to have gotten so insanely popular now, has the advantages of higher bioavailability for some constituents. It has some very significant limitations. And in addition to that, it has that increased risk of adverse effects that other routes of administration don't have. When you know even a little bit about the pharmacology of essential oil constituents, I think that you can start to understand why oral use of essential oils doesn't deserve the popularity that it seems to have acquired. And in all this drama and brouhaha about oral use, a lot of us, and I think that includes some people in aromatherapy, a lot of us seem to have forgotten that this modality is called aromatherapy for a good reason. And that reason is that so many of the effects that we hope to get from using essential oils, again, are probably coming from those central nervous system actions that require inhalation. And those people that we study in our courses, like Marguerite Maury and Paolo Rovesti, and some of those others who did so much of the early work and research in aromatherapy, we're doing a lot of it, or even most of it, on those central nervous system effects that could be produced by inhalation. We are aromatherapists. We are not ingestion therapists. And one of the things that I kind of get on my soapbox about is I don't want to lose the aroma in aromatherapy. So aside from the advantages of olfactory nerve stimulation that you get from inhalation of essential oils, I think a lot of people don't realize that you also get excellent bioavailability with inhalation. A well-known and often quoted study published in 1993 by Falk Philipson and colleagues showed a bioavailability of 70% for limonene inhaled by male volunteers, and the few other studies that have been completed on humans have shown that the bioavailability of various essential oil constituents by inhalation runs between about 60 and 70%. While a bioavailability of 60% clearly isn't as high as one of 96%, you can't really argue that it's not enough to produce results, because the bioavailability of a great many drugs, pharmaceutical drugs, taken orally is much less. I'll go back to morphine because I know a little bit about morphine. And bioavailability of morphine taken in oral solution, which is the most effective way to administer it orally, is only 23.9%. But you can hardly argue that it's not able to be effective because that's not high enough bioavailability. We know that morphine is effective at that level of bioavailability. It's a matter of adjusting the dose of the drug. So when we talk about inhalation giving you a 60 to 70% bioavailability of the constituents administered, that's pretty good. It's still lower enough than oral administration to avoid some of the risk that come with taking essential oils internally, the risk of some of those particular types of toxic effects that I talked about. The one application in which I worry a little bit about inhalation is in those situations where you are using nebulizing diffusers, especially in small spaces, to deliver high volumes of essential oil, because I think if you're in that situation for a while, your blood levels can begin to get pretty high and your risk begin to become higher as well. And in addition to that, it's been found that essential oil constituents can react with other things in the air, and I think specifically it's when you're in the presence of machinery that generates negative ions, things like copy machines and a lot of medical equipment and stuff like that. When essential oils are in the air in that situation, they combine with those ions, I think, to form formaldehyde. And of course, formaldehyde is a strong respiratory system irritant and possibly a carcinogen. So we need to be careful about diffusing these really large amounts of oil. And I think about the only time that that's a justifiable thing is for fighting infections during outbreaks or when there's a strong likelihood of an outbreak. Massage therapists who work in small, poorly ventilated rooms all day, especially if they're running diffusers on top of the massage, they're getting essential oils through the skin and through the respiratory system, and I think they also can have some pretty high risk for toxicity. And in fact, I've seen a fair number of massage therapists over my years of practice who have signs of chronic toxicity. So topical application, I'm going to have to speed it up here a little, I think. Topical application is the least effective way to get essential oil constituents into the blood, and the bioavailability of essential oil constituents applied topically may be on average about 6 or 7%. The way that we typically use essential oils, we're probably getting more than that because we're getting it through respiration. Now, I want to skip down here and look at this slide. I'll just kind of tell you what it's about, and you can look at it at your leisure. This is a study that was done. I forget when was done actually, but it was summarized by Tisserand and Young in their latest book on essential oil safety. And it just shows the peak serum concentration levels that were achieved by various essential oil components through different methods of application. And this kind of just goes along pretty much with what I was saying. The first thing we can say about this is that there was some absorption of essential oil constituents by every route of administration studied. And according to the information given, that included dermal with inhalation, and oral. The fastest rate of absorption was seen with combined dermal inhalation application, the next fastest with oral, and the slowest with dermal. I think we can safely conclude from this that inhalation is the fastest route of absorption. And you may be saying, well, they didn't study inhalation by itself, but there have been other studies that have looked at that and that would back that up. So inhalation is the fastest route of absorption. Dermal application is the slowest, and that's consistent with other research. Oral is in the middle. So the rate of absorption of a drug or essential oil constituent determines how quickly it can act, but it's an indicator of how quickly that drug is going to be cleared from the system as well. And when it's cleared from the system, its effects are over. So the faster a drug can be absorbed, the faster you get an effect, but the quicker that effect ends, which means that you'll need to reapply it more frequently to maintain the effect. How quickly a drug or essential oil constituent is cleared from the system is indicated by a measure known as half-life, and I can just give you an example of this. Half-life is the amount of time it takes for half the drug to be eliminated So if we look at a common essential oil constituent known as limonene, its half-life by inhalation is 1.25 hours, but by oral administration, it will work for its half-life is 5.6 hours. So limonene is going to work faster if you inhale it than if you take it orally. But in order to maintain its effect, you need to administer it more frequently by inhalation than by oral use. Now, this is this would be a great area for research because I've taken several well-known people's courses on aromatherapy, and I've attended a lot of lectures. And this issue of how frequently to administer essential oils by various routes has never been really addressed to my satisfaction. Different people make different recommendations. It's not that anyone doesn't make recommendations, but I've never felt that those recommendations were based on really solid understanding of the pharmacokinetics. And obviously, how frequently you need to re-administer would vary from oil to oil because they would have different half-lives. And it would also vary in terms of whether or not you even need a sustained effect. If you're using an essential oil for pain relief because you pulled a muscle on your back, you might need that effect overnight or even for a few days. But if you want to use it to help overcome anxiety while you're giving a 10-minute presentation, then you don't need it to last so long. And that's an example of when it would be much better to inhale it than ingest it, because you need it to act fast, you don't need it to act long, and that's a situation in which you might well specifically need some of those central nervous effects that you can only get by inhalation. The last thing I'll say quickly about this slide is that while all of these studies tell us that some amount of essential oils were absorbed in each case, they don't tell us whether or not any of those amounts were high enough to produce a therapeutic effect. And some of my students will look at those values there, like the 1 nanogram per milliliter value for camphor in study number 1, and they'll say, well, that couldn't possibly be enough to exert an effect. But the truth is, we hardly have any information at all on what the minimal effective levels are for most of these constituents. We do have it for some drugs, and we know, for example, that some of those pharmaceutical drugs are effective at very low concentrations. Fentanyl patches, for example, which are widely used now in the treatment of chronic pain, they only achieve peak serum levels of something like 1.9 nanograms per milliliter. They're effective at that level, and that's only just a little bit higher than the level reported in study number 1. All right, I had hoped to be able to spend some time looking at factors that affect absorption. You'll be able to see these by looking at the next slides. Let me see what I've got here. It'll take me a minute to get that slide in place. Ooh, I went too far. Let's see. All right, so let's look at dermal absorption gradients of essential oil constituents with and without dilution. What this slide is telling you is that essential oils are absorbed most effectively when they're applied undiluted, and that's true, but please don't take that as an indication that you should apply them undiluted, because there really are significant risks associated with that, and we really shouldn't do it. The fact that you may have applied them undiluted and not gotten bad effects has virtually no meaning. You could get sensitization reactions at any time, and when you are working with people in clinical situations, you can provoke that effect in some of your clients. At any rate, that's the best absorption. Next is in a gel-based medium, and you work your way down sequentially until you get to vegetable oil. An essential oil mixed with vegetable oil gives you the least effective absorption. And actually, sometimes that can be an advantage because you may be dealing with something on the surface of the skin, and you want that oil to stay on the surface as long as possible. So in that situation, that's an advantage. All right, next slide. These are the effects of various factors on dermal absorption, and they're pretty self-explanatory. You can look through them here and get most of what you need to get. I just want to add to the temperature issue, which is second on the list, that the increase in absorption of essential oils associated with warming the skin can be very significant. One study by Hotchkiss showed that a 10 degrees centigrade, which I think would be about a 50-degree Fahrenheit, increase in the temperature of an oil suspension in which volunteers' hands were immersed resulted in a 7-fold increase in the rate of absorption. And in regards to the issue of occlusion covering the skin, which is under that, this effect is also very significant. In a study performed in 1990 by Branaugh, it was found that 75% of a topical dose of fragrance compounds was absorbed when the skin to which it was applied was covered, while only 4% was absorbed if the site was left uncovered. When I read that study for the first time, I immediately started using essential oils in my practice by applying warm compresses, because you get two things in that method. You do get the increase in temperature, and you also get the occlusion, the covering of the skin. And I chose hot compresses specifically because I do not like to see essential oils applied to the skin and covered with plastic wrap. Number one, if you cover it with plastic wrap, that increases your risk of skin irritation. Heat increases the risk of skin irritation too, so you have to be careful with that as well. But I don't like plastic wrap, period. I worry about what might go from the plastic wrap into the skin. But with hot compresses, you get the benefit of some occlusion. You get the benefit of the temperature. And I have found hot compresses to be a very effective method for a lot of things. They're my method of choice for things like menstrual cramps and indigestion. But I think they have a lot of applications because I think they do significantly increase the amount of essential oil you can get into the blood if you're using it topically like that. There are several other slides under here. The next one shows some essential oils with high levels of potential neurotoxic constituents. These are oils that I try to avoid. Some of them have other side effects as well. When we're talking about inhalation, you see age and pathologic lung conditions will lower or alter the rate of absorption through the respiratory system. And the rest of these are just really kind of additional things that you don't need to worry about. The last slide gives you the web addresses to access my teaching. And that's all I have for tonight. I hope it's been helpful. I hope I haven't moved so fast that you haven't been able to keep up with any of it. But thank you very much. And that's all I have.
Thank you, Joey. That was great. A lot of information to absorb, literally.
Yeah, absorption is the issue, isn't it?